Guys, we're going to touch an important area in pharmacology, not only in pharmac, also for community medicine or for any other topics in the future. We have respiratory medicine, general medicine. Of course, the topic is regarding tuberculosis. Drugs used for the treatment of tuberculosis. As per TB is concerned, again, we are moving towards the next important era in treatment of tuberculosis, and that is NTEP, National Tuberculosis Elimination Program. So based on this, we have revised lots of we have added lots of newer drugs. We have revised the previous regimen. We have taken out lots of unwanted drugs, which is there in the previous regimen. So a deeper knowledge on those drugs is going to be a very much important one. And most importantly, with a recent surge in the increase in the intake of inhalational steroids. Inhalational steroids, people are more, if they are regularly taking inhalational steroids, they are more prone to land up in pulmonary tuberculosis also, because steroids tend to have an immunosuppressive property which might produce super additive infections, especially with tuberculosis. Let's start with the case scenario. A 35-year-old male with complaints of cough, persistent fever, night sweats, and a known case of major depressive disorder was diagnosed as MDR-tuberculosis, multi-drug resistant tuberculosis. Which of the following anti-TB drugs is contraindicated in this patient? We have four major options here: cycloserine, clofazimine, linezolid, Bedquilin. If you want to answer this question, for example, if you are in your clinic and you face a tuberculosis patient and you have a doubt, you send a sputum sample. 2 sputum sample comes back as positive for tuberculosis, and the patient is already a known case of major depressive disorder. And it is an MDR-TB, which drug is contraindicated? That's what the question is. So if you want to answer this question, you need to have a basic knowledge on what are the basic symptoms of tuberculosis, how do we diagnose a patient with tuberculosis, what are the drug of choice for multi-drug resistant tuberculosis, and what drug should not be administered in a patient with major depressive disorder, and what are the contraindications and classical features of individual anti-tubercular drugs. So for gaining this knowledge, let's move towards the individual topics here. As per drugs used in treatment of tuberculosis, we have two major points: first line drugs, second line drugs. Please note that the first line drugs are having high efficacy but low toxicity, and the second line drugs tend to produce low efficacy but at the same time tend to have more toxicity symptoms. So if you design a newer drug for the treatment of tuberculosis and you want it to be added in the first line anti-tubercular agents, you have to make sure that the efficacy is very much higher and also the toxicity profile is comparatively lower. So how we are going to walk through in this topic of tuberculosis is, we are going to explain regarding the first line anti-tubercular drugs, we will be explaining the second line drugs, the newer drugs, then we will be explaining regarding the National Tuberculosis Elimination Program, drugs used in the treatment of Isoniazid resistant, Rifampin or multi-drug resistant, extremely drug resistant tuberculosis, and all these things we are going to talk about in this particular session. What are the first line anti-tubercular drugs? HRZE. 4 major drugs are there: Isoniazid, Rifampin, Pyrazinamide, Ethambutol. If Isoniazid is starting with I, why do we have a need to start with H? Because it's purely based on the chemical name of that drug. So Isoniazid is denoted as H, Rifampin denoted as R, Pyrazinamide denoted as Z, and Ethambutol denoted as E. We used to call them as HRZE. As per second line drugs is concerned, we have thiacetazone, para-amino salicylic acid, ethionamide, cycloserine, carnamycin, amikacin, capreomycin. All these drugs are aminoglycosides. We have fluoroquinolones. Also, we have rifabutin, rifampin, and a newer addition, linezolid. Apart from all these drugs, we have 2 newer drugs to be added in this treatment regimen. One is Bedquilin, the other one is Pretomanid. These are the names of anti-tubercular drugs, guys. Let's talk about the mechanism of action of individual anti-tubercular drugs. For explaining the mechanism, we are going to draw the diagram of a basic schema of what exactly is a tuberculous bacteria. So in this diagram, I'm going to explain only regarding those targets which we currently have as per treatment process is concerned. I'm not going to be overloading you with all the different details with which microbiology faculty have taken that. Now I'm not going to be details of it, just those classical points with which we have drugs against. Consider, as we can see in this diagram, consider this is your Mycobacterium tuberculous bacteria. We have the cell wall, and inside we have the cell membrane. Inside the cell, we have the nucleus, and we have the protein synthesis which is happening. From the nucleus, we have 2 major enzymes which is involved, which is primarily an important target for some of the anti-tubercular drugs. The first enzyme is DNA-dependent RNA polymerase, DDRP, that's called as DNA-dependent RNA polymerase. The next enzyme is DNA gyrase enzyme. We have protein synthesis which is happening inside the bacteria, and we have an enzyme called as ATP synthetase enzyme. This ATP synthetase enzyme which is there inside the cell is responsible for multiplication of that particular bacteria. Why does a tuberculous bacteria gain entry into the human body, guys? Because it needs an area, it needs to utilize the enzymes for its proliferation. Why are the human beings living in this world? Because we need an area for our proliferation, for our reproduction. That's why we are here. That's why we are here in this earth, right? If there is some better world is available, we'll move on to that. That's what the normal nature of a human being. Here we have the cells which is going to be multiplying within your lungs. So for that multiplication, it needs an energy molecule. ATP is going to be synthesized with the help of an enzyme, ATP synthetase enzyme. Now we have the cell wall here, which is there on the bacterial cell, Mycobacterium. I'm just going to explain something more. We're just going to zoom in into the cell wall and look at the nature of this individual cell walls. So from the inside towards the outside, we have many different layers which has been set up to prevent the damage, to prevent the cell from getting into damage. The lowermost part, we have the cell membrane. Immediately outer of that, we have molecules called as arabinogalactans, Ag molecules, arabinogalactans. These arabinogalactans are fused with the cell membrane with the help of LAM molecules, lipoarabinomannan molecules. Of course, we have peptidoglycan cell wall which is there between these two different layers. These are peptidoglycans. Like similarly how we have explained regarding the cell wall synthesis inhibition, penicillins and cephalosporins, here also we have the same concept. We have cell wall which is made up of peptidoglycan. Outside the layers, that's to say outside the arabinogalactan layer is where your mycolic acids are. We have the mycolic acids. On the extreme outer part, we have mycocytes. Of course, we know Mycobacterium tuberculosis is an acid-fast bacilli. We know the reason behind it is because of mycolic acids which is there on the extracellular area. These are the different layers of cell wall of a Mycobacterium tuberculosis bacteria. We have two major enzymes which is involved in the synthesis of mycolic acids, that is fatty acid synthase type 1 and fatty acid synthase type 2. As I have told, I am just going to be explaining only regarding the targets. I am not going to be digging deeper regarding how this is going to be involved in the synthesis of mycolic acids. Two major enzymes involved here are fatty acid synthase type 1, fatty acid synthase type 2. The second, we have arabinogalactans. These arabinogalactans, for the synthesis, we need an enzyme, that is arabinogalactan synthetase enzyme. Arabinogalactan synthetase enzyme. Now, for the synthesis of peptidoglycans, we have the peptidoglycans. I hope you remember that. No, we have D-ALA, L-alanine, and D-glu, all the other amino acids which is fused. We have explained it more regarding the cell wall synthesis area itself. So this, for this synthesis of this peptidoglycan layer, we need an enzyme, and that is racemase enzyme. We have an enzyme called as racemase enzyme. These are the different enzymes, the targets which we currently have as per treatment of tuberculosis is concerned. Now we'll go back to the area where we're going to be, we read regarding the bacterial cell wall, and bacterial cell contains nucleus and the protein synthesis. First, we have seen about an enzyme which is acting in the nucleus, that is DNA-dependent RNA polymerase. That enzyme is inhibited by rifampin, the first drug. We have DNA gyrase enzyme which is inhibited by fluoroquinolones. Fluoroquinolones like ciprofloxacin, norfloxacin, moxifloxacin, levofloxacin, especially the respiratory fluoroquinolones will be involved here. Protein synthesis will be inhibited by streptomycin, that is your aminoglycosides. Then we have sutizolid, linezolid, and the derivative of that, sutizolid. These are oxazolidinone agents. These drugs also will inhibit the protein synthesis in a mycobacterium. Then we'll move on towards the next enzyme which has been explained, ATP synthetase enzyme. That enzyme will be inhibited by the newer drug Bedquilin. Bedquilin will inhibit ATP synthetase enzyme. Let's come to the cell wall area. On the cell wall area, we have seen about 1, 2, 3, 4 major enzymes. Let's start with racemase. This racemase enzyme will be inhibited by cycloserine. Cycloserine, again we have explained that in cell wall synthesis inhibitors itself, guys. Cycloserine. Then we have drugs which might be inhibiting arabinogalactan synthetase enzyme inhibited by ethambutol. E is that drug. Ethambutol tend to inhibit arabinogalactan synthetase enzyme. Fatty acid synthase type 1 will be inhibited by pyrazinamide. Fatty acid synthase type 1 will be inhibited by pyrazinamide. Fatty acid synthase type 2 will be inhibited by isoniazid. Fatty acid synthase type 2 will be inhibited by isoniazid. Apart from that, we have some other cell wall synthesis inhibitors like Delamanid, Pretomanid. Delamanid and Pretomanid. So these are the different drugs which we currently have in treatment of tuberculosis. What are the first line drugs, guys? Isoniazid, Rifampin, Pyrazinamide, Ethambutol, HRZE. What's the mechanism of action of isoniazid? It inhibits fatty acid synthase type 2. Rifampin, it inhibits DNA-dependent RNA polymerase, DDRP enzyme. Pyrazinamide inhibits fatty acid synthase type 1. Ethambutol inhibits arabinogalactan synthetase enzyme. These are the different first-line anti-tubercular drugs, and I have given the mechanism of action of those drugs too. Let's move on to the individual drugs, like especially the first-line drugs. We'll be talking in detail what exactly is isoniazid, rifampin, pyrazinamide, and ethambutol, and the classical features of individual drugs. Isoniazid tend to be, we used to call them as a highly selective agent. Isoniazid is a highly selective agent, especially for Mycobacterium tuberculosis. Rifampin can be used for other conditions, like it can be used for leprosy or Neisseria meningitidis, but it cannot be used, but isoniazid cannot be used like that. It can be used especially for Mycobacterium tuberculosis infections. The second point, is it static or sedal? It is both. It behaves as both. Isoniazid behaves as battery-static agent in terms of resting bacilli, whereas it behaves as battery-sedal agent for rapidly multiplying bacteria, which means those rapidly multiplying Mycobacterium tuberculosis bacteria is there now, it is going to be killing it off. Those bacteria which are dormant, which is not multiplying, it is going to be behaving as a static one. Already they are dormant, it just continues to be a dormant one. Is it going to be affecting the intracellular or the extracellular bacilli? We know tuberculosis bacilli might be there in two different areas. It might be there in the blood or it might be there inside the cells. Which bacteria will be targeted most? Both intra and extracellular bacilli will be killed off by your isoniazid. Where it is going to be producing the effects? Is it in the alkaline medium or in the acidic medium? Why? Because in terms of inflammation, there will be gaseous materials. So in terms of gaseous material, we know that inflamed area are already having an acidic pH in that. So whether this drug will be working in those conditions or not, we have to have a knowledge on that. This drug will work both in acidic medium and in the alkaline medium. Moving towards the pharmacokinetic features of isoniazid, very important one, guys, as per the exams is concerned. Please note that this isoniazid is a prodrug, right? It's a prodrug. It must be converted to the active form with the help of an enzyme called as catalase peroxidase enzyme. This catalase peroxidase enzyme is a protein which is synthesized from transcription translation. Transcription means some gene molecule is going to get stimulated, and that gene is CAT-G gene. KAT-G is the gene which is responsible for the production of catalase peroxidase enzyme. So isoniazid is a prodrug. It is converted to the active form by catalase peroxidase enzyme. This active form in turn is going to be producing all the anti-tubercular activity. What about the metabolism of isoniazid? Isoniazid in turn will be broken down to inactive metabolites by acetylation. Acetylation, of course, you remember it from the general pharmacology itself, guys. We have two different forms of acetylators. Some patients might behave as a slow acetylator. Some will behave as a fast acetylator. Fast acetylator means this drug will be metabolized at a faster rate and the T-half of that drug is going to be shorter. As slow acetylator is concerned, this drug will be metabolized at a slower rate. The active form of drug will be there within the body for a longer duration of time and the patients will be having a longer half-life, which means fast acetylators average will be having a T-half of those drugs is around 1 hour. Slow acetylators, T-half of isoniazid is somewhere around 3 hours because T-half is prolonged in terms of a slow acetylator agent. As I've told, this drug tend to have action both in the acidic and in the alkaline medium, which means this drug has got a good penetration into gaseous material. We'll rewind back to general pharmacology, guys, where we have explained about microsomal enzyme inducers and inhibitors. Isoniazid behaves as a microsomal enzyme inhibitor. We have two drug interactions. The first one is para-aminosalicylic acid inhibits isoniazid metabolism, so thereby increases the half-life of isoniazid. The second one, aluminum hydroxide inhibits the absorption of isoniazid. What's the take-home point of aluminum hydroxide, guys? Aluminum hydroxide is nothing but which is commonly seen in terms of any gels like your gastrointestinal. It's an antacid gel, right? So it is better not given along with HRZE, isoniazid, to say treatment for tuberculosis, because it might hinder the absorption of isoniazid. These are the important pharmacokinetic features of these drugs, guys. How resistance is getting developed? Simple, CAT-G gene gets mutated. When the CAT-G is getting mutated, isoniazid will not be converted to the active form, which means that drug will not work against that particular bacteria, mechanism of resistance development. What are the adverse effects of isoniazid? We have 5 major points. You have to remember that. Usually in your classes, you would be remembering only 1 point or maximum of 2 points, but you have to remember all the 5 different points. It produces peripheral neuritis. There is CNS adverse effects. Patients might develop hepatitis, hematological reactions, and hypersensitivity. All these 5 are important adverse effects of isoniazid. Let's dig deeper regarding these adverse effects alone. I have told that this drug tend to produce peripheral neuritis. Why is it? Because it tend to interfere with the utilization of vitamin B6. Pyridoxine utilization will be interfered, thereby there is going to be more excretion of pyridoxine from the body. Pyridoxine is prevented to be accumulated from the body. As pyridoxine has been lost, the patient will be having peripheral neuropathy, like pain, symptoms will be there. Patients will be having paresthesia and numbness in their fingers or in their peripheries. It will be most commonly seen whenever the drug is getting accumulated in the body. When there is more accumulation of drug in the body, there might be a possibility of that, which means slow acetylators or fast acetylators. Yes, peripheral neuropathy will be common in terms of a slow acetylator. This drug will not get metabolized, half-life is prolonged, it is more prone to produce peripheral neuritis. Risk of peripheral neuritis will be more in terms of elderly, pregnant women who are co-infected with HIV, who are already known diabetic, alcoholic, and uremic patients. In all these patients, there is more chances of peripheral neuritis. As a treatment, we can give pyridoxine around 100 milligrams per day can be given as treatment. As prophylaxis, to prevent the occurrence of these conditions, I can use pyridoxine 10 milligram per day as a prophylaxis. The next adverse effect is what CNS is. CNS, it might produce seizures. Isoniazid might produce seizures in known patients who are known epileptogenic. There might be memory loss and psychosis. The third one is nothing but a hepatitis slice. Hepatitis, it manifests in the patients as loss of appetite, nausea, vomiting, and jaundice. There is more risk in terms of elderly and also in alcoholic, but most importantly, we have to know that hepatitis or hepatotoxicity of isoniazid is more common with fast acetylators. Isoniazid, when given with slow acetylators, more prone to develop peripheral neuritis. When given fast acetylators, more prone to develop hepatotoxicity. Next, we have hematologic reactions. Patients might develop agranulocytosis, thrombocytopenia or anemia, and some patients might develop hypersensitivity reactions also, which is also very much rare. These are the ADRs of isoniazid, guys. Please have those concepts in mind. Isoniazid, rifampicin, these two form the basic and the most important drugs in treatment of tuberculosis. Moving on to the next drug, rifampicin. Rifampicin is actually derived from Streptomyces mediterranei. Point number 1. Point number 2, is it bacteristatic or bactericidal? Isoniazid behaves as static against some, cidal against some. Rifampicin behaves especially and only as bactericidal agent. What about rapidly dividing bacteria or slow dividing bacteria? Against which bacteria rifampicin will be more effective? It has got action only on slow dividing bacteria. It has got very less activity against rapidly dividing bacteria. Is it affecting the extracellular or intracellular tuberculosis bacilli? Again, like isoniazid, both extra and intracellular will be broken down by rifampicin. There is some chances of enterohepatic circulation, so thereby the half-life might be prolonged in some patients. The other important features of rifampicin is mechanism of resistance development. We have RPO gene. Mutation in RPO might produce resistance development as per rifampicin is concerned. Let's talk about the adverse drug reactions, guys. Most important one regarding rifampicin is adverse drug reactions. Why ADR is, you have to think of it as a basic concept, buddy. Which drug's adverse effect is very much important, which drug's adverse effect is not that much important. Of course, ADR is going to be very much important for all the drugs, but which one we need to have a more concentration on is, just think that which drug is being given for a longer duration of time. Right? Isoniazid, rifampicin, anti-tubercular regimen, we give it for 6 months or 9 months or 12 months, right? Based on the individual regimens which we have, right? So it's going to be given for a longer duration of time. We have to have a knowledge on all the adverse drug reactions of those drugs. Any short-acting drugs used only for shorter duration, like it is used only for around one time stat dose, 1 dose, 2 dose, 3 doses, or for 2 days, 3 days, no need to worry about that much regarding adverse drug reactions. You have to have a knowledge more on the drug interactions of those drugs. Is that clear? Now, let's talk about the adverse effects of rifampicin. Most important one is hepatitis, right? Hepatotoxicity is the most important adverse effect with rifampicin. Also, there might be orange-red colored discoloration of secretions from the body. Might be urinary tract or saliva, or even some patients might have orange-red colored tears have reported. If a patient has got lens in it, right, the contact lens, if a patient is using contact lens and the patient is taking rifampicin, there might be permanent discoloration of the contact lens too. We have to throw it, replace it with one more contact lens. Apart from that, we have 4 other syndromes which is associated with it. Respiratory syndrome might be seen with rifampicin. 4 major syndromes are there. The first one is respiratory syndrome, cutaneous syndrome, abdominal syndrome, flu-like syndrome. Respiratory syndrome is nothing but patients might be developing breathlessness, shock and collapse. Cutaneous syndrome, patients might develop flushing, rash and pruritus might be developed. Abdominal syndrome, patients might develop nausea, vomiting. Flu-like syndrome, patients might develop chills, fever and headache. These are the other adverse effects of rifampicin, guys. What about microsomal enzyme studies? Is it microsomal enzyme inducer or inhibitor? We know that isoniazid serves as a microsomal enzyme inhibitor. On the contrary, rifampicin will behave as microsomal enzyme inducer. It is inducing the microsomal enzymes. That's the reason why it has got a lot of adverse drug reactions in relation with the drug interactions. For example, if a patient is on contraception, if a patient is taking oral contraceptive pills, and the same patient has landed up in Mycobacterium tuberculosis infections. You give isoniazid rifampicin combination. Rifampicin serves as a microsomal enzyme inducer, right? And now the patients will be having the oral contraceptive pills will be damaged. More oral contraceptive pills will be broken down to inactive forms, leading on to decreased contraception, causing contraceptive failure might be. You might be having a doubt. Sir, I'm giving both isoniazid and rifampicin in this patient, right? Right, I'm giving a microsomal enzyme inhibitor and also I'm giving a microsomal enzyme inducer. What will happen in that? This induction inhibition will be in balance, right? It will not happen, guys. Why? Because when you give a microsomal enzyme inhibitor and an inducer for a same patient, what will happen to the microsomal enzymes? First, there will be inhibition. Why? Because inhibition is a simple concept. This drug will bind with microsomal enzyme and it prevents its action. It's a direct concept. It will happen immediately whenever we administer these drugs. So microsomal enzyme inhibition will occur first. Microsomal enzyme induction. What is microsomal enzyme induction? It binds with the nucleic acids, increases the synthesis of those microsomal enzymes. It takes a lot of time to occur, but once it occurs, it is going to be overtaking the microsomal enzyme inhibition. So when you give isoniazid and rifampicin both in this patient, immediately there is going to be microsomal enzyme inhibition, but after a period of time, say 4 weeks or 5 weeks, there is going to be induction of microsomal enzymes, which is going to be overtaking the inhibitory property of isoniazid. This induction is because of rifampicin. Rifampicin can be used for Mycobacterium, it can be used for Staphylococcus, it can also be used for Neisseria meningitidis and Haemophilus influenzae. Moving on to the next drug, we have Pyrazinamide. Again, we have some classical features of pyrazinamide. It is effective only against acidic medium, guys. It is not effective in alkaline medium, point number 1. Which means it is effective only inside macrophages and at the sites of inflammation. It is not effective in other areas. Again, this drug is a prodrug. It must be converted to the active form by an enzyme called as pyrazinamidase. Pyrazinamidase will convert this drug to the active form. Most important adverse effect associated with pyrazinamide is hepatotoxicity. Again, it's a drug which tends to inhibit fatty acid synthase type 1. It is producing hepatotoxicity. Patients might develop hyperuricemia. These two are very much important for pyrazinamide. Patients might develop nausea, vomiting. Some patients might develop drug fever, skin rash might be developed because of pyrazinamide. What about the last first-line anti-tubercular drug, Ethambutol? Please note that all the first-line anti-tubercular drugs are bactericidal in nature, except Ethambutol. Ethambutol behaves as a bacteriostatic agent. It is more effective against rapidly multiplying bacilli only. It has got zero effect on static bacteria or dormant bacilli. Adverse effect of ethambutol, remember E is for E, ethambutol is for I. It produces optic neuritis and some patients might develop hyperuricemia also. So with this, what we have seen till now, guys, hyperuricemia can be seen with both drugs, two drugs. What are those? Pyrazinamide, Ethambutol. Hepatotoxicity can be seen with 3 drugs. Yes, hepatotoxicity can be seen with 3 drugs. Isoniazid, Rifampin, Pyrazinamide. Out of all these 3, which produces maximum hepatotoxicity? Pyrazinamide will produce maximum hepatotoxicity. These are the basic concepts regarding first-line anti-tubercular drugs, guys. Now we'll move to the next one, second-line anti-tubercular drugs. Among second-line, we have some injectable agents. Injectable drugs includes aminoglycosides like streptomycin, we have amikacin, capreomycin, kanamycin. We have some fluoroquinolones like ofloxacin, levofloxacin, moxifloxacin, and ciprofloxacin. These drugs are fluoroquinolones which can be used as second-line anti-tubercular drugs. Other oral second-line anti-tubercular drugs, we have ethionamide. Please note that ethionamide is associated with severe hepatotoxicity. Similarly, we have prothionamide. We have cycloserine. Whenever I say cycloserine, you have to remember this basic concept. It is associated with neurotoxicity and neuropsychiatric disturbances. The next drug, we have terizodone. We have para-aminosalicylic acid. We have seen one interaction regarding para-aminosalicylic acid. It tends to inhibit the breakdown of isoniazid. Not only that, it also inhibits the resistance development for isoniazid. Rifampin, it is not given with concomitant live bacterial vaccines. There might be increase in the effects of those. Rifampin might be producing Stevens-Johnson syndrome. Out of all these agents, the one drug with which we have seen a case scenario previously was the patient was being diagnosed with tuberculosis. She was having typical symptoms of TB and she was diagnosed with TB. She also had additional major depressive disorder also. So which of the following drugs is going to be contraindicated? That was the question which was asked previously. Now the answer for that question is cycloserine. For that you have to understand what are the contraindications for the use of cycloserine. Cycloserine is contraindicated in terms of epilepsy because it might precipitate seizures. It is contraindicated in terms of psychiatric illnesses like depression, severe anxiety, or in psychosis because it might worsen those particular conditions. Those patients might land up in worsening and lead to severe psychosis or severe depression. Example, this case which we have dealt with, this is the case of major depressive disorder. I should not administer cycloserine in that patient. Severe renal insufficiency, it might produce cycloserine toxicity because the drug will not be thrown out from the body. These are the bases regarding the second-line anti-tubercular drugs, guys. What about the newer ones? 2 major drugs were there, right? Pretomanid and Bedquilin. Pretomanid is a peroral drug. It is given after food. Please note these important points regarding Pretomanid. It has got 4 major set of adverse drug reactions. First is in the liver, in bone, in eyes, and LA. Liver, it produces hepatotoxicity. In bones, it produces bone marrow depression. In eyes, it produces optic and also peripheral neuropathy. And in LA means lactic acidosis might be seen with Pretomanid. What about the next drug, Bedquilin? Bedquilin, it is actually one of the most famous drugs, guys. Because why? Because the first one, it's a diaryl quinoline derivative. It's a bactericidal agent, but not because of this. The primary thing is, it was the first drug which has been approved, especially for tuberculosis. A newer drug approved for tuberculosis after a long gap, for around 40 years. Right? For the 40 years, we don't have any newer drug for tuberculosis. Bedquilin was the first drug to be approved after 40 years of gap. It is not actually a newer drug, as it was approved long before 2002 or 2012, this drug was approved. But till now, we see it as a newer drug. The T-half is going to be 5.5 months. It has got a very long T-half. It is not recommended for more than 6 months. Adverse effects of Bedquilin includes nausea, arthralgia, headache, and 2 major areas are there. It might be associated with severe hepatotoxicity, QT prolongation in the heart. As it is producing severe hepatotoxicity, we have to take LFT before the therapy and we have to take it periodically. As it is producing QT prolongation, we have to take ECG before and during the therapy with Bedquilin. These are the pharmacological features of individual drugs which we currently have in treatment of tuberculosis. Now let's move on to the regimen which we currently have, that is NTEP, National Tuberculosis Elimination Program. Under this program, we are going to explain about the presumptive TB criteria. What are the criteria with which we can diagnose a patient with tuberculosis? First one, the patient must be having cough for more than 2 weeks. Fever must be there for more than 2 weeks. There must be significant weight loss. Some patients might be having hemoptysis associated with that. X-ray we might look some abnormalities on the X-ray. 2 sputum samples should be collected, a spot sample should be collected, and an early morning sample should be collected, and both has to be investigated with CBNAT, that is cartridge-based nucleic acid amplification test. After doing this CBNAT, once the results comes back as positive, he will be diagnosed as a tuberculosis patient. Previously, we have a guideline called as RNTCP, Revised National Tuberculosis Control Program. Now we have NTEP, National Tuberculosis Elimination Program. The difference between these two is, the first point is, what's new in the newer tuberculosis regimen is we have changed it to a daily regimen. Previously, we had weekly, weekly, we have to take it in 3 days a week, Monday, Wednesday, Friday, or Tuesday, Thursday and Saturday. But now we have daily regimen. Now we have fixed dose combinations. There is no treatment categories. We have previously had treatment categories. Now we don't have treatment categories. The categories is purely based on weight of the patients. We have lots of newer drugs which has been included in this newer regimen. Injectable aminoglycosides or injectable drugs has been taken out from the first line therapy. It has been included in the second line therapy. Like previously, streptomycin was treated as first line anti-tubercular drug. Now it has been changed up. It has been pushed towards second line drug. And the treatment is going to be primarily based on drug susceptibility, which means previously it is not so, but now in terms of NTEP is concerned, when you face a patient in your clinic with the typical symptoms of cough, fever, weight loss, hemoptysis, and you doubt the patient, you take up an X-ray, you find gaseous materials, you find cavities, and you send the sputum samples, you find out the sputum sample comes back as positive, you diagnose the patient as tuberculosis. Now they have to see the sputum culture sensitivity reports. From the sputum culture sensitivity reports, it will be coming up as this patient has been diagnosed with, this patient has got Mycobacterium tuberculosis in his sputum, and the tuberculosis bacteria is going to be sensitive to these different drugs, resistant to these different drugs. Look at the resistance patterns. If it is resistant to isoniazid, it belongs to a separate treatment category. If it is resistant to isoniazid and rifampicin, separate treatment category. If it is resistant to some other drugs, treatment category is going to be separate. So this treatment of tuberculosis is primarily based on drug susceptibility testing. We have 4 different nomenclatures, new terms which is included in the NTEP, National Tuberculosis Elimination Program. The first one is lost to follow-up. What is defined as lost to follow-up? The patient is started on treatment and the patient left treatment after 1 month. When the patient has treated for more than 1 month and the patient has lost follow-up. The patient is not coming up regularly. We don't know where the patient is. This will be called as lost to follow-up. We have second term, failure. What is called as treatment failure? Treatment failure explains sputum comes back positive at the end of recent treatment. The patient has completed a treatment regimen, and after the treatment regimen is completed, you send up a sputum sample and comes back as positive. It will be called as failure, treatment failure patient. What about recurrence? The patient, you have started a treatment regimen, they have completed the treatment, the patient, you have sent the sputum sample, sputum comes back as negative, there is no tuberculosis there, there is no tuberculosis bacteria in there, we have been declared as cured, but he came back after some week as positive, or some days or some months as positive. This will be called as recurrent tuberculosis. What is drug-sensitive tuberculosis? Drug-sensitive tuberculosis means if the patient or if the bacteria is sensitive to isoniazid and rifampicin, it will be called as drug-sensitive tuberculosis. Again, we have some newer definitions regarding resistance patterns of tuberculosis. We have around 5 different types, guys. The first one is called as mono-resistant. We have multi-drug resistant, poly-drug resistant, extensively drug resistant, pan-drug resistant. What is mono-resistant? Resistant to any one of the first-line anti-tubercular drug. He will be called as mono-resistant tuberculosis patient. The bacteria will be called as mono-resistant tuberculosis. Whereas we have multi-drug resistance means the patient is resistant to isoniazid and rifampicin. He will be called as multi-drug resistant. Among the mono-resistant, which we have explained previously, we also have isoniazid resistant, H-resistant tuberculosis. That is resistant only to isoniazid, but he is sensitive to all the other drugs. The third one, we have polydrug resistant. He is resistant to more than one first-line anti-tubercular drug, but not to isoniazid and rifampicin. Isoniazid rifampicin is sensitive, but he is resistant to pyrazinamide and ethambutol. He will be called as polydrug resistant tuberculosis. Extensively drug resistant means, it's an important question. Extensively drug resistant means if a patient is resistant to isoniazid, rifampicin, any one fluoroquinolone, any one injectable aminoglycoside agent. If the patient is resistant to 1, 2, 3, 4 isoniazid, rifampicin, 1 fluoroquinolone, 1 aminoglycoside, then he will be termed as extensively drug resistant tuberculosis. We have a separate treatment process for that. Pan-drug resistant, also called as total drug resistance or extremely drug resistant. Extensive drug resistant is different. Extremely drug resistant is different. Extremely drug resistant means he's been resistant to more drugs than any of these going to be inclusive. Now let's talk about the treatment of tuberculosis. Before going further, I just have a question here. If a patient has been diagnosed as tuberculosis along with HIV, right? Simply, if we know that tuberculosis is one of the most common opportunistic infection in a patient with HIV. What should be treated first? Is it tuberculosis or is it HIV? See, buddies, we have also explained that in antiretroviral drugs also. The concept here is, whenever a patient has been diagnosed with HIV, his immune system will be dropped down. All the CD4 plus T cells will be broken down, right? There will be no immune system. And also superaddictively, because there is no immune system is very much weaker, those patients are immunosuppressive, there is superadded tuberculosis infection in those patients. The tuberculosis bacteria will be starting to multiply and the patients will not be having any symptoms, but there will be tuberculosis bacteria which is constantly multiplying there. Because symptoms is primarily because of the immune system's response. In those conditions, how do we treat those patients, guys? If you treat the HIV at first, what will happen? All the HIV started to be getting, all the HIV load is going to be decreased. Slowly CD4 plus T cells will be increased. Immune system will be reconstituted. The immune system will be reconstituted and all the immune system will start targeting this tuberculosis bacteria. Patients will be having severe flare-up of symptoms. This is what we call it as IRIS, Immune Reconstitution Inflammatory Syndrome. To prevent that from occurring, whenever a patient has been diagnosed with HIV and tuberculosis, we don't treat the HIV at first. We give treatment for tuberculosis at first. When you treat the tuberculosis bacterial load is getting decreased, and after that, if you give an anti-HIV drug, even if the immune system is getting reconstituted, inflammation syndrome will not occur in those patients. So TB with HIV, we prefer to treat TB first, followed by HIV. How do we treat the tuberculosis first? We have many different treatment processes. We have first line treatment process. We have two different phases for that, intensive phase and continuation phase. Intensive phase includes HRZE is given for 2 months, and for continuation phase, we use HRE given for 4 months. HRZE given as a single drug dose. We have one fixed dose combination. We use it for 2 months, right? 1 month means the usual value which you take up is 28 days. It's not 30 days. 28 days is the usual value which you take up as a month. 28 days into 2 is equal to 56 doses will be administered on the intensive phase. So when a patient has been diagnosed, simply put, patient visits you, symptoms, sputum sample, positive, sputum culture sensitivity, you diagnose the patient as tuberculosis, drug sensitive tuberculosis, you give HRZE, fixed dose combination, 56 doses will be given to the patient. Daily 1 tablet you have to take for the next 56 days. He takes this HRZE tablet for the next 56 days. On return back, you just write him a follow-up sputum sample. Sputum sample will be sent, it comes back again. The patient will move on to the continuation phase. In the continuation phase, we have HRE alone. We don't give pyrazinamide there, we just give ethambutol. 4 months it has to be administered. Again, it has to be administered for 4 days, 28 into 4, 112 doses of that HRE must be given to the patient. Patient will be taking it daily 1 tablet the patient will be taking. After completion, we take up a sputum sample. Sputum sample comes back as negative. If a sputum sample comes back as positive, it will be called as treatment failure. Clear? How do we clinically follow up the patient? This is where when all you have to take up a sputum sample immediately after intensive phase, immediately after a continuation phase. How about clinical follow-up, guys? Every month we have to clinically follow up the patients, and long-term follow-up we have to ask the patient to come back and examine the patient clinically for every 6th month, 12th month, 18th month and 24th month. So till 2 years the patient should be coming up for follow-up to see any other further symptoms, or we can also, if there is a query, we can send the sputum samples also. Now comes the next one, how to administer this fixed dose combination. Here the category is purely, as I've told, it is not based on treatment process, it is purely based on the weight category. We have 4 or 5 different categories are there. The first category, weight of the patient is from 25 kgs to 34 kgs. Second category, 35 to 49 kilograms. Third one, 50 kilograms to 64 kilograms, 65 to 75, more than 75. So now comes the next one, right? You give those drugs, guys, before giving for the patient, he comes, he diagnoses it. You give these drugs before giving the drugs, you ask the patient to, you just look at the weight of the patient, right? Based on the weight, you categorize the patient into these 5 different categories. Intensive phase, we have to give 2 drugs per day if the patient is 25 to 34 kilograms. The next category, 3 tablets. The next category, 4 tablets. The next category, 5 tablets. The next category, 6 tablets per day. Similarly, for continuation phase, 2 tablets, 3 tablets, 4, 5 and 6 tablets. You have to calculate the number of tablets. Just use a calculator. That's enough for you, right? So you need to have 3 different things, right? You need to send sputum samples, point number 1. The second one, you need to have a weighing machine to calculate the weight. The third one, you have to have a calculator to calculate the number of tablets to be given for the patient. If you have all these things, you are tuberculosis, TB specialist, right? Or a chest medicine specialist. Please don't do that, guys. We have to study it properly. Respiratory medicine is a separate subject. Now let's talk about the treatment process for isoniazid resistant tuberculosis. If a patient is resistant to isoniazid but sensitive to rifampicin, rifampicin is sensitive only resistant to isoniazid, then he will be given up a regimen called as LRZE regimen for 6 months. LRZE means levofloxacin, rifampicin, pyrazinamide, ethambutol is given for 6 months, not 2 and 4, no, there is no intensive or continuation phase, just we give LRZE for the next 6 months. What about MDR tuberculosis? What exactly is MDR-TB, buddies? If the patient is resistant or if the bacteria is resistant to isoniazid and rifampicin. 2 different treatment processes. Again, here we have an intensive phase and a continuation phase. Intensive phase will be lasting for around 6 to 9 months. Continuation phase will be there for around 18 months. We use 6 drugs in the intensive phase and 4 drugs in the continuation phase. What are the drugs which can be used for MDR-TB? Please remember with this order, guys, we have LKZE ethioclo. This is for intensive phase. For continuation phase, LE ethioclo. L is for, as per IP, intensive phase is concerned, L is for levofloxacin. K is for kanamycin. Z is for pyrazinamide. E is for ethambutol. Ethio is for ethionamide. Clo is for cycloserine. For continuation phase, we have LE ethioclo, which means levofloxacin, ethambutol, ethionamide, cycloserine. These drugs are given for a period of around 18 months. This is the treatment process for MDR tuberculosis. This is a longer regimen. We have a shorter regimen and a longer regimen. What I have given you is the longer regimen. What about the treatment process for extensively drug-resistant tuberculosis, XDR-TB? XDR-TB means what is that? The patient is resistant to 4 major concepts: isoniazid, rifampicin, 1 fluoroquinolone, and 1 injectable aminoglycoside agent. If a patient is resistant to any all of these 4, he will be categorized as XDR-TB and he will be given 3 major drugs here. It's called as BPAL regimen. B is for Bedquilin, P is for Pretomanid, and L is for linezolid. These 3 drugs has to be administered in those conditions, especially when a patient is diagnosed with XDR tuberculosis, guys. That's it about the treatment process for tuberculosis, buddies. So till now we have seen about one important case. That case is purely based on cycloserine-induced neurotoxicity or neuropsychiatric disturbances. Then we explained about individual first-line the drugs which we have, first-line drugs, second-line drugs, the newer drugs, and we have seen the important features of NTEP, how to diagnose a patient with TB, what are the different treatment process which we have, what's the drug of choice for drug-sensitive, isoniazid resistant, multi-drug resistant, and XDR tuberculosis.